Hi, I'm Oliver Grimm. I'm a senior psychiatrist at the University Clinic Frankfurt, where I work in the clinic of psychiatry. And I work in CoCA within work package 4 and 6. My main interest is in neuroimaging of the reward system, and today I would like to present you some hopefully interesting stuff about how ADHD and obesity are connected by a dysregulation of the reward system. So why is obesity interesting for clinical medicine? According to stuff you will find on the WHO website from June 2016, the prevalence of obesity has more than doubled within the last, 35 years. So people older than 18, we have about 600 million people who are obese, and a much bigger number, maybe almost 2 billion adults, are overweight. So these are simply the fact. So a lot of the world population today living in industrial countries and developing countries are nowadays overweight. So why is being overweight or being obese a problem at all? That's another interesting fact. So 41 million children under the age of 5 were overweight in 2014. Well, and when talking about overweight and obesity, you have to know some basic definitions. So being overweight is defined as a body mass index greater than or equal to 25. So everything below 18 is pathological due to illness, anorexia, whatever. Above 25, it's being overweight, and obesity is a body mass index greater than or equal to 30. So a problem with the body mass index, as you can imagine, is it's a quite crude measure. People coming out of a fitness studio, it's not me, but maybe some trained patients I saw, have a very high body mass index. And that's not because of body fat, but of muscles. So the body mass index, as I said, is a crude measure. There are some alternative measures. I will tell you stuff about this. So measuring in more precise details the exact body fat composition, or another interesting measure, the waist to hip ratio. So this figure gives you some basic impression how body mass index looks when it comes to the body proportions. So it's clear even above 25 and well above 30, these people have accumulated some body fat, which at least in the Stone Age was no real problem. So as I asked before, and as I said now, problems. Well, that's medical textbook knowledge. High blood pressure is linked to obesity, high body fat, blood fats, cholesterol, triglycerides, and these are markers for an increased risk of damaged vessels, so cardiovascular risk. In addition, type 2 diabetes is clearly linked to being overweight or obese, and blood pressure and diabetes over the course of years really damage your blood vessels. That leads to coronary heart disease, that leads to stroke. Another disease which is linked to nutrition is gallbladder disease and osteoarthritis. So fat body simply because of the weight, puts more pressure on the joints. It is linked to sleep apnea, it is linked to some cancers, and it is linked to mental illness. Of course, the question is mental illness because of being overweight or the other way around. So we are interested within CoCA in ADHD and how ADHD and obesity are linked. So in a highly interesting meta-analysis by Cortese from 2016, it is said the putative association between ADHD and obesity might seem paradoxical because rather than being hyperactive, individuals with obesity are often described as lazy. However, the impulsivity and inattention that characterize ADHD might lead to dysregulated eating patterns with consequent weight gain. Sounds very easy, however, just some remarks. Not everybody with ADHD is hyperactive. Especially in adulthood, a lot of patients present with an inattentive subtype. Eating behavior is definitely more than impulsivity. So what exactly is a dysregulated eating behavior? These are questions. So ADHD and obesity. This meta-analysis I mentioned, on the right you see the graph, comes after combining lots of studies to a relatively low odds ratio when it comes to ADHD and obesity, 1.17. Nevertheless, it's statistically significant. And if you look on the graph on the right side, it's very heterogeneous. So there are very small studies, there are big samples with a very small confidence interval. And if we just look at the effect for medicated patients, there's no effect. And in this meta-analysis, just the unmedicated patients had a odds ratio of 1.43. However, meta-analysis cannot generate new data if the quality, phenotyping of some of these samples is maybe not bad, but especially when it comes to body mass index, as I said, a crude measure, or eating behavior, just the weight might be not so informative. So there are some samples which looked, for example, at a longitudinal course. ADHD in childhood or adolescence. Do these children, young people, become obese? And in a 33-year-old follow-up in almost 200 boys, the odds ratio for obesity was almost 3. Interesting paper. It's mentioned in the CoCA grant proposal. So if you want to read a good study, read this one. So as I said, I'm interested in the neurobiology of ADHD, especially when it comes to dysregulated reward mechanisms in a meta-analysis by Michael Plichter in Neuroscience and Biobehavioral Reviews. We find these combination of studies and this figure. So the anticipation of reward, for example, in a monetary incentive delay paradigm, I will explain in some minutes what this exactly is. We find that the reaction of the reward system, you see in A, the striatum and the ventral striatum, this reaction to rewarding cues is lower in ADHD. And that's something we find across several studies. So let's call it blunted anticipatory response to reward signals is lower. So let's look at the neurobiology of obesity. Simple question, is there a common pathway between addiction and obesity? That's an idea which is put forward by Nora Volkow and collaborators. There is a highly interesting article, How Can Drug Addiction Help Us Understand Obesity, in Nature Neuroscience, but you will find several other reviews by Nora Volkow which deal with this idea, especially with the help of radioligand labeling of the dopamine 2 receptor and PET techniques. So in A, you see the neuroanatomy of the reward system. Most important thing in blue, the ventral tegmental area, which has some projections to the striatum and other parts of the brain. And in B, you see the reaction in the bottom to amphetamine. So amphetamine is a real strong drug when it comes to modulation of the dopaminergic reward system, whereas on the top you see the almost same effect for food. However, if you look on the y-axis, of course, amphetamine is much, much stronger. Nevertheless, food reward can um, lead to such a surge of dopaminergic release within the striatum. So, as I said, that's something put forward by Nora Volkow and collaborators, for example, in the article Brain Dopamine and Obesity. And in some of the work by this group and other people, we see how the brain reacts to different drugs. The figure on the right gives this for several drugs: cocaine, methamphetamine, alcohol, heroin. And on the right, you see how the brain of an addicted person reacts to PET neuroimaging. So how much D2 labeling of the D2 receptor is possible. So, and we see there is lower D2 labeling, which implies a lower activation of the dopamine system, something which is commonly interpreted. These people need drugs or maybe food when it comes to obesity to kind of homeostatically counter a lower blunted response of the reward system. And in obese subjects, that's something found too with this PET technique. However, PET is quite static. Interesting question is, how do these people react in more, well, common life, ecologically valid paradigms? In B, you see that at least in obese subject, there's in addition a link to the body mass index. So even if I said body mass index is a crude measure, nevertheless, it's a clear index. And people with a body mass index not only above 30, but as you see in this graph, between 45 and 60 are really obese. So when talking about reward, as I said, so on the left, some basic facts about the reward system. Important thing, the ventral tegmental area has projections to the nucleus accumbens, main core part to the frontal cortex, to the striatum in general. And in the middle, you see, well, the function of the reward system when it comes to this dopaminergic reward signaling. That's from a famous work by Wolfram Schultz, who did a lot of work. So if you're interested in this whole reward story, read reviews by him. Normally, when a reward appears, as you see on the top, the brain reacts by this, dopamine flash. And if this reward is combined in time, reward, stimulus, which signals the reward, then the signal goes from the reward to the conditioned, to the time of the conditioned stimulus. That's learning. So we need dopamine for learning. And on the very right, you see a wide array of differing stimuli. So social cues like sweet neonates, babies, um, fast food, cocaine, and associated paraphernalia, and simply gold, money. And all these cues and rewards induce such a dopaminergic reward. So I want to give you a very short overview what methods there are to assess obesity, eating behavior, and this reward learning. These methods are applied within work package 4. So if you're interested, you can look into the intranet documentation or just contact me directly. So our colleagues from Spain, Barcelona, especially for work package 6, set up this really good fitness test or combination of fitness um, tests for body composition, which is more detailed as, in comparison to the simple body mass index, and to physical fitness in general. So simple thing is waist circumference for waist to hip ratio. So especially in men, but in general in human beings, much of the body fat, which is deposited more in the middle, in the belly, is associated with a higher cardiovascular risk. So while some women might complain about the body fat in their arms, the people who really have a much higher risk are these men with some strong bellies. Strong arm and strong bellies might, well, it's not a good combination. So waist to hip ratio might be easy to obtain and is a good add-on or alternative to body mass index. This caliber you see on the top middle, you insert into this thing some skin and measure the body fat beneath the skin. So skin fold thickness at several parts of the body gives the body fat composition. Body mass index is clear. That's available in a lot of studies. And physical fitness, chest to step test, with varying degrees of, well, speed. You have to step on this box and your pulse is measured. Hand grip test, the muscular strength. Pushing this device is measured. And the standing long jump breath test is simple too. People just jump and it is measured how far they come, and that's a quite good index for health and muscular strength. So if you're interested in this, have a look at this fitness manual, which is available in work package 6. So in work package 6 and work package 4, we use one scale, the Yale Food Addiction Scale, which asks about which tries to grab the eating pattern in a very addiction-related way. That's available too on the internet. There are other alternative questionnaires for eating behavior. However, these are not used so far within the CoCA project, and might try to measure other things like disinhibitory eating, stuff like this. So what I'm interested in is measuring this reward learning. Here you see a monetary incentive delay task. So a reward cue, this arrow signals a reward will appear. When the target comes, people have to push a button, and depending on how fast they are able to push this button, they are awarded some reward, monetary incentive, delay task. And after this fixation period, they see the reward outcome. That's what we use in work package 4, trying to find out differences between ADHD and ADHD with different comorbidities like addiction disorders, depression, or obesity. In addition, we use a delay discounting paradigm. So people see something like on the left, it's put in dollars. We use it with euros. So today, a lesser reward, or in the near future, a bigger reward. And we have steps of 2, 4, 6, and 8 weeks. But people get a little bit more. So internally, they have to calculate. Well, I'm a very impulsive person. I don't want to wait, so I want the money now. That's the plausible idea how people with ADHD will react. Or maybe, well, I don't need the money now. I can wait for ages, so taking a reward in 8 weeks and only 5 cents more is completely fine with me. So now I'm at the end. I hope I gave you some basic insight how ADHD and obesity might show similarities to substance use disorders and are maybe connected by this. So the idea is that a hypoactive dopaminergic system might predispose vulnerable individuals to obesity. So drugs or at some point food can, well, let's say, hijack the dopamine system in the right figure. You see this in the middle. And this system has, from start on, some dysregulation in people with ADHD. So that might explain why at least some people with ADHD are predisposed to develop obesity. So if you have questions, I cannot answer them interactively right now, but just send me an email, oliver.grimm@kju.de. See you on some CoCA meeting or related conference. Goodbye.